The OPTIC trial was designed with the intent to investigate what's the optimal dose of ponatinib. Ponatinib was approved with a standard dose of 45 milligrams daily, highly effective, but then we recognized the issue of the arterial occlusive events. And there was some suggestion that these were related to the dose that was being used in the patients. So this study was then a randomized study where patients that had been refractory or intolerant to prior tyrosine kinase inhibitors were randomized to receive ponatinib at a starting dose of either 45 milligrams, again, the standard, 30 milligrams, or 15 milligrams. And the primary endpoint was to achieve a BCR-ABL of 1% or less at 12 months. Another important element of the design is that patients who achieved that endpoint, if they were receiving 45 or 30, they were mandated to reduce to 15 milligram daily dose. So eventually everybody would be getting 15 milligram dose. This is an interim analysis, so 77% of all the patients are being included. Everybody who has reached the 12-month mark or who has discontinued therapy. The final analysis would be when everybody reaches the 12-month mark or discontinues therapy. And 99% of the patients, 98% of the patients had received at least 2 tyrosine kinase inhibitors, 50% had received at least 3 tyrosine kinase inhibitors, and really all but one of the patients were resistant to therapy with a prior tyrosine kinase inhibitor. So what the results show is, number one, in terms of efficacy, do the 3 dose levels work equally? The primary endpoint, as I said, was a BCR-ABL of 1% or less. And these occurred at 12 months, and these occurred in 39% of the patients that started at 45 milligrams daily, but only in 27% of the patients who started at either 30 or 15 milligrams. Actually, those two were exactly the same. So that suggested that the 45 milligram daily dose was superior to the other doses. But more importantly is that when you look at it by mutations, these included patients with any mutation. So the subset of patients that had T359 mutation, the difference in response rate was even larger. So at 45 milligrams, it was 42%. At 30 milligrams, it was 24%. And at 15 milligrams was 8%. There was a difference also in the patients that did not have T359, although those differences were smaller. So overall, all of these suggest that there was a benefit with the higher doses. It's also important to notice that the dose reduction that was mandated per protocol, there were a few patients who lost their response, but essentially these responses, when they were lost early. Nobody who has maintained the response 90 days has lost the response after the 90 days. Of course, we need more follow-up, but that seems to suggest that this lowering the dose is safe. Now, in terms of efficacy, in terms of safety, no big surprises here. Thrombocytopenia was the most common adverse event. In terms of the non-hematologic adverse events, hypertension was the most common in 24% of the patients, but only 7% of them had a grade 3. There was also 6% of the patients had a grade 3 elevation of lipase, but no real pancreatitis. That was not a significant problem. But the big question is the arterial-occlusive events that occurred during the trial. And for these, to evaluate these arterial-occlusive events, we had a panel of independent cardiologists and neurologists and vascular experts to assess every reported case to make sure that they completed the criteria for the American College of Cardiologists and the American Heart Association of an arterial-occlusive event. So the incidence of any arterial-occlusive event that met this criteria was 5% for the 45 milligram cohort, 4% for the 30 milligram, and 1% for the 15 milligram cohort. So there was some trend also for more with the 45 milligram cohort compared to the 30. But that difference was relatively small. So certainly what appears to the results appear to show sort of a conclusion of these interim analyses is that although there is a correlation between dose and both efficacy and safety, the gain that you have with the 45 milligrams daily dose is much greater than the increased risk that you have by going to the 45 milligrams. Certainly, it's good to see that all these doses are effective, they're all safe, and it's also good to know that these reducing the dose according to response seems to lower the incidence of these arterial occlusive events. So I think these results provide good guidance on how we should manage patients with this drug that is very effective, but that we have been sort of struggling to try to find that right balance between efficacy and safety.